Hello, everyone, and welcome to Caring and Living as Neighbors parallel event at the NGO CSW69 Forum for the United Nations 69th Commission on the Status of Women. My name is Nikki Pasterchik. I am a molecular biology student at Lehigh University and a UN Youth Representative for CLAN. I will be co-hosting this event with Katie Blomqvist, my fellow UN Youth Representative, and Kate Armstrong, the president and co-founder of CLAN. Just for some housekeeping, please ensure you are muted if dialing in virtually. Lastly, this event will also be recorded and posted with a report soon on the CLAN and Mates for Kids websites. We would like to acknowledge the traditional owners of the lands that everyone is dialing in from virtually. We invite you to post the traditional lands you're on in the chat now. From Lehigh University, I am in Bethlehem, Pennsylvania of the United States, and I acknowledge that I am presenting from the lands of the Lenape people, and I pay respect to elders past, present, and emerging. As CLAN is based in Australia, we acknowledge the traditional owners of country throughout Australia and recognize their continuing connection to land, waters, and community. We pay our respect to First Nations peoples internationally and to their cultures and elders past, present, and future. This event is in partnership with the Lehigh University United Nations Youth Representative Program. The Lehigh Youth Representative Program started in 2008, where high-achieving Lehigh students are matched with UN-accredited NGOs. CLAN is one of 13 NGOs and one of Lehigh's strongest partners. CLAN currently has 4 UN Youth Representatives: Katie Blomqvist, Tara Chevlem, Samiha Islam, and myself, who advocate for CLAN at United Nations events such as this one. This program allows youth to have a voice in global matters, and in our case, advocacy for children who are living with non-communicable diseases in resource-poor settings. The priority theme of CSW69 is to focus on current challenges that affect the implementation of the Beijing Declaration and Platform for Action and the achievement of gender equality and the empowerment of women and its contribution towards the full realization of the 2030 Agenda for Sustainable Development. The Beijing Declaration was adopted in 1995 at the Fourth World Conference on Women in Beijing. The Beijing Declaration identified 12 critical areas where urgent action is needed to advance women's rights, including women in poverty, education and training, women in health, violence against women, women in armed conflict, women in the economy, women in power and decision-making, institutional mechanisms for the advancement of women, human rights of women, women in the media, women in the environment, and the girl child. Our event, titled Showcasing the Power of Women in Childhood NCD Community Development, aims to address several of these critical areas, including women in health, women in power and decision-making, human rights of women, and the girl child. Now I'd like to introduce you to CLAN. CLAN, short for Caring and Living as Neighbours, is an Australian non-governmental organization founded in 2004 by Dr. Kate Armstrong. CLAN is committed to equity for children living with chronic health conditions in resource-poor settings. CLAN's strategic framework for action focuses multi-sectoral action on 5 pillars. Pillar 1 is affordable access to medication and equipment. Pillar 2 is education of the individuals, families, communities, health professionals, policymakers, and the international community. Pillar 3 is the optimization of medical management, including primary, secondary, and tertiary prevention with a biopsychosocial focus. Pillar 4 is the encouragement of family support networks. And the final 5th pillar is reducing the financial burden on families that result in poverty, helping people to become financially independent so that they can provide the necessary healthcare for their children long term. CLAN is focused on promoting equitable access to newborn screening services for all children of the world, as it supports the early diagnosis and treatment of many chronic conditions of childhood that are associated with preventable morbidity and mortality. Special efforts are going to be needed to reach babies from resource-poor settings and families. A rights-based approach is at the core of CLAN's mission to support children living with non-communicable diseases and other chronic health conditions. This approach recognizes that all children, regardless of their health status, have the right to the highest attainable standard of health, as outlined in the United Nations Convention on the Rights of the Child and other human rights frameworks. CLAN's child-friendly rights flyers educate children, families, and communities about their rights in a simple, accessible way. They raise awareness, promote self-advocacy, and help families demand better healthcare, education, and support. As advocacy tools, they also empower stakeholders to engage policymakers. By equipping families with this knowledge, CLAN fosters a more inclusive, equitable society where all children can thrive. See the link in the chat to view our CAH or congenital adrenal hyperplasia child rights flyers. Newborn screening programs ideally support comprehensive approaches to the early diagnosis of congenital anomalies and can include physical examination of the body, hearing and vision checks, pulse oximetry, and heel prick blood spot testing. For those unfamiliar with the specifics of newborn blood spot screening, it is a heel prick method where blood samples are taken from a newborn and tested for multiple genetic, metabolic, endocrine, and other long-term conditions. This is pivotal for children with chronic conditions, as early diagnosis and treatment within a few days of birth can prevent morbidity and mortality. Mates for Kids uses the WHO Knowledge Action Portal on NCDs as the primary platform for connecting our community of practice. The CAP is a knowledge sharing and community platform dedicating to enhancing NCD prevention and control through multi-sectoral and multi-stakeholder collaboration. We encourage you to join our community. Find the links in the chat below to learn how to register. I'd now like to introduce Dr. Kate Armstrong. Dr. Kate Armstrong is an Australian public health physician and a fellow of the Australasian Faculty of Public Health Medicine. She is president of CLAN, founding chair of NCD Child, and co-founder of Mates for Kids.
Thank you very much, Nikki, for that very kind introduction. If you could go on to the next slide, please, that would be great. It's a real pleasure to be here today and just share a brief introduction to Mates for Kids. Thanks, Nikki, for that introduction to CLAN. And it's really timely with this 30-year review of the Beijing Declaration, 30 years on. Last year, CLAN celebrated our 20th anniversary, and sorry, Nikki, I was still on the last one, but we celebrated our 20th year and really committed at that point to reduce the mortality associated with CAH by 2030. And part of that is with our 40 grants. So there's all these numbers swirling around at the moment, and I'll just introduce those a little bit more. So thanks, Nikki. The next slide. Thank you for the acknowledgement of country at the start, Nikki. I'll acknowledge that CLAN is based on headquarters on the land of the Wallumattagal people of the Eora Nation here in Sydney, Australia, and acknowledge the traditional owners of the unceded lands across Australia, but also of the lands you're all dialing in from. As part of acknowledging elders, really excited about acknowledging the incredible speakers we'll have on today. The 5 priorities to faster gains that were identified in the Beijing Declaration, the review process, identified 5 cross-cutting recommendations, and one of those was to elevate women's voices. And we have some incredible women and allies joining us here today to talk about the work that they're doing. So thank you, Nikki. Next slide, please. So As I mentioned, I'll be talking a bit about the 30% by 2030 and the 40 grants and the 3 objectives for NCD Child, but then also talking about how we actually hear from champions and how Mates for Kids works. Thanks, Katie. Thanks, Nikki. So Mates for Kids is a global movement of individuals and organisations, and we've all come together around a big, hairy, audacious goal, really, of reducing the preventable mortality associated with CAH, congenital adrenal hyperplasia, a childhood non-communicable disease, chronic health condition. And we're inspired by the SDGs, particularly SDG 3.4, which commits to reducing preventable mortality by 30% by 2030. And we're really looking at, I'll just put things on mute there, sorry. We're really looking at applying that to CAH. We also acknowledge that by committing to this SDG, we're helping contribute to SDGs 3.2.1 and 3.2.2, which are focused on reducing early childhood mortality. We first came together, we were inspired by the situation in Zimbabwe, and we'll be hearing from the team in Zimbabwe today. We wrote a briefing paper to WHO in February 2022, and we're very, as Nikki mentioned earlier, we're very grateful to the WHO GCM on NCDs for allowing us to host a platform on the Knowledge Action Portal that WHO holds. Thanks, Nikki. Next slide. How are we planning to reduce the preventable mortality associated with CAH? We've identified 3 key strategies, and we focus all of our attention on those 3 things. The first is improving access, affordable access to essential medicines, diagnostics and equipment. The second is by strengthening CAH communities, and the third one is scaling newborn screening. Thanks, Nikki. We focus all of our activities on those 3 things. So I'll start by talking about access to essential medicines, which, as you saw in CLAN's strategic framework, Pillar 1 is one of the biggest priorities. You're right to progress, please, Nikki. So access to medicines are essential. Children with CAH, much like other childhood NCDs, such as type 1 diabetes, they need these medicines. Childhood cancer is another example. They can't survive and thrive without affordable access to these medicines. They risk dying if they don't get them at all, and really experience tremendous side effects if they don't have the right dose. And if families can't afford it, they have to ration doses. The UN Convention on the Rights of the Child makes it really clear families have a right to access the medicines that they need to survive and thrive. So this is really a human rights effort. Next slide, thanks, Nikki. Strengthening CAH communities is vitally important, and we really use CLAN's strategic framework for action, as Nikki discussed before, bringing CAH communities together from around the world. We're hearing from a range of different WHO regions today, and it was just very touching to see this message from the Indonesian CAH community sent to Colombia on the event of their inaugural meeting in 2024. And it just shows the power of coming together and caring about each other. And we have speakers from Indonesia and Colombia today. So that just felt really lovely to find that old message there. And the third approach, Nikki, with the next slide, thanks, is around scaling newborn screening. Nikki introduced us to newborn screening at the start. Newborn screening is it's an accepted this is a human rights issue as well. We have our written statement, highlights the importance of newborn screening. We'd encourage you to take a look. And we're grateful to connect with many newborn screening champions around the world through the Mates for Kids network who are doing incredible work. And we love to showcase the work that they're doing. Thanks, Nikki. The next slide, please. So just in closing there, just briefly, how do we work with Mates for Kids? Well, we have the CH community at the centre. It's an honour. We've got CH community members speaking here today. I consider myself a member of the CH community. I have a family member with CAH. I'm never going anywhere. I'll be part of the CH community forever. So the CH community voices, they really need to be at the centre of everything we do. But we couldn't do it without our allies. We need to work with as many different groups as we can to drive the change that we need. We focus on those three objectives: access to medicine, strengthening communities, and newborn screening. And we're honoured in Mates for Kids to bring people from each of the 6 WHO regions of the world. We attend events, we have community of practice meetings, we are committed to 40 grants by 2030. We've issued 11 grants to 8 countries so far, and we have an exciting announcement at the end of the meeting today about our next round of grants, around 5 grants that will be launched today. But we now have grants in 8 different countries, and we'll be hearing from some of the grant recipients today. They're all collecting data and helping to track our progress as we track towards 2030, and we're excited about that. I'd like to now hand over to Katie, but in closing, I really want to thank our Lehigh UN youth reps, of which Katie is one. We couldn't do it without the young volunteers, and we really just can't thank them enough. So over to you, superstar Katie. Thank you.
Hi, everyone. My name's Katie Blomquist, and I'm one of the UN Youth Representatives for CLAN, and I am the Mates for Kids Project Officer, as well as a Master's of Public Health student at Lehigh University in Pennsylvania in the United States. So today, we are very excited to be launching the Mates for Kids Annual Activity Report. If you want to go to the next slide. One more. Thanks. Yeah, so today we are launching the latest version of the activity report. This report spans from July 2023 to December 2024. It captures the incredible progress of the Mates for Kids network and the progress we've made over the past year and a half, as well as the challenges we continue to face in our mission to reduce preventable mortality associated with CAH by 30% by 2030. It highlights the incredible work of our network of champions across the 6 WHO regions who are working tirelessly to improve access to life-saving treatments, strengthen community development, and scale newborn screening programs worldwide. So inside this report, you'll find key achievements from our global community of practice, inspiring success stories from local champions in the Philippines, Colombia, and Pakistan, strategic framework guiding our work in improving access to medicines, strengthening communities, thank you, and scaling newborn screening, tools to track the progress as we work towards our 2030 goals, and updates on the impactful work of our community development grant recipients. The report is both a celebration of our progress and a call to action. It underscores the importance of collaboration, the power of community-driven solutions, and the urgent need to address healthcare inequities for children with CAH and other chronic conditions. So I just included a few snippets from the report, but in the chat, you will see a link to the Mates for Kids website where you can access this report and look through all the pages. It's pretty hefty. It's about 40 pages, but we encourage you to take a look and learn something new. And yeah, we're very excited to be launching this today. So I hope everyone finds it useful, everyone learns something new, and yeah, take a look in the chat and you'll be able to see it there. Thank you so much.
Thank you so much, Katie. So now I'd like to introduce our first speaker, Harriet Mondawa. Harriet Mondawa is the managing partner at Jide Consultants and founder of Endocrine Southern Africa Trust. With 10 plus years of industry experience in the Cayman Islands and Zimbabwe, she completed her PhD in February 2025. A dedicated leader and mother of 4, she is committed to advancing endocrine health in Southern Africa.
Thank you very much, Nicole. We can move to the next slide. Hello, everyone, once again. The power of mothers and communities striving for equity in Zimbabwe. This is what I'm here to talk about today, and I'm very excited to be here. Thank you. We can move on to the next slide, Nicole. So just to give a bit of context, women are the primary caregivers in Zimbabwe. Hence, they shoulder the caring of children, especially those with rare disorders. So from my personal experience, my child was diagnosed at birth, and this is the last born out of 4. So the first scan that was taken by the radiologist revealed that she had everything intact. She had ovaries and she was a girl. But then after subsequent examinations, because she was born with an ambiguous genitalia, referred us to an endocrinologist. And I was like, what is an endocrinologist? This was my first time hearing of this. So we went to the endocrinologist, and they informed me that my daughter had a rare condition called CAH. So at that point, I decided in my own mind to find a doctor or a surgeon who could probably give some of my body parts to my daughter so that at least she could, not get to take the lifelong medication. But the doctors were saying that it's not possible because our organs are not compatible. So I tried to, research around CAH and find out what it was. But, reading is reading unless you then find some practicalities to then say, okay, there are other people out there. So in my search, I came across CARES Foundation. This was in the early stages of 2020, late 2020. And then they were very resourceful and helpful to me. I think they were more of a counseling platform for me. So they introduced me to other women who had CAH, some 60-year-olds, some young girls, different people who had CAH. And I can tell you, I fell in love with CAH. I was so happy that my daughter had CAH because of the things that I would hear about the people and how they've lived and how they were taking care of their children. Now I'm with the people that I have around me, the community itself. I make sure that everybody falls in love with it because I grew to be grateful of my child and of the condition that she had. And I was also able to listen to some of the podcasts and their meetings, the monthly meetings where they would have the endocrinologist and the surgeon and all that. Plus, they also referred me to a doctor. The doctor I currently use right now is in South Africa. I really wanted a second opinion. So I was then referred by CARES. And I'm so grateful because then I managed to get the surgeon who did my daughter's operation this year, and it was so successful. I'm so grateful. So I have gotten to realize that when a child is born with conditions that are rare like that, we need to enjoy them and embrace them. And this is what I have done. But that's not without its challenges. We can go on to the next slide, Nicole. Thank you. So there are many challenges that I've faced as a mom here in Zimbabwe, the cultural barriers, the discrimination. So I have to keep it a secret about my child's illness because people start asking and, suggesting different things of how it came to be. Yet I know that my daughter was born the way she was. So I've tried to keep it as close-knit as possible. The only people that know are those within my household and the people at her school. Basically, and now and again, the doctors that attend to us. So the other challenge we faced is the difficult in diagnosing. For example, at first, they were not sure about the presence of ovaries. So when my child was born, there was a scan, and the scan revealed that she did have ovaries. But then we were referred to the surgeon. The surgeon said the scan is not really showing these ovaries, so she needs to go through an endoscopy. And I was not sure about the endoscopy thing. I think this is when my mind wanted me to have a second opinion. That's how I came to that. But we did go through the endoscopy and it showed that she had ovaries and everything was there. And then when I then went to the second opinion, who was referred by CARES, he told me that the endoscopy was really not necessary because the scan had already shown that her ovaries were there. So, and they were also able to informed me that my daughter was a salt waster. So this was also done by the second opinion, the doctor that I use, who is in South Africa. He told me that she was a salt waster, and I only got to know about her salt wasting after 2-3 years. So she started taking fludrocortisone after a while. So I think this is the difficulty with the diagnosis of rare conditions. And then also the doctors that attend to adrenal crisis, these are mainly at the emergency rooms. So really, they're not really vexed because they change frequently. Most of them didn't know or don't know about CAH. So each time I would go there with an adrenal crisis, I would tell them to give her hydrocortisone first, but then they have their way of doing things. So we'd end up arguing and arguing, but I would win the argument. I would win the argument at the end of the day, thankfully. And they would then reason to say, okay, let's do it this, or they would then call her endocrinologist, and then she would give them the assurance that it's okay to take the medicine, the hydrocortisone first. And also the other challenge we face is scarce medication. And if available, it is expensive. So I remember when my daughter was born, there was no hydrocortisone at all. All pharmacies didn't have. I had to fly out to South Africa to buy hydrocortisone. And when I got the hydrocortisone, I bought for 6 months and brought it back home just to make sure I had enough for the time being. And but if it's available, it's quite expensive, because for a month's supply, it's about $48. That's for depending on the dosage. But in other spaces, for me at least, I do have medical aid coverage, which is better. I find that is better. But for my other counterparts, my other colleagues, they do not have medical aid, and this is the majority of the CAH patients, they do not have medical aid. So this brings me to how I then came to start ESAT, the Endocrine Southern Africa Trust. We can move on to the next slide, Nicole. Thank you. So the hope that we have and the help that we have is that I founded ESAT with the aim to help children with endocrine disorders. Endocrine disorders, this includes CAH. So for the other endocrine disorders, there are only 1 or 2 children. So I thought no one would even want to start an organization with 1 or 2 children. So why not incorporate them into this trust and then just call it Endocrine Southern African Trust. So visibility, we are grateful. Personally, I have no words, but Klein has been very helpful to me and the community, the CH community, because they gave us our very first donation. And I can tell you, we're still very excited around this. We are really taking our time to build the website because this donation is going towards that. We want to incorporate vernacular language, which is Shona here, which most people understand, and English. We want to include a lot of information and how they can write their names and just register there. All those little details, we want them onto that website. And the donation is also helping us to create material for distribution. This will enable us to be visible and to actually source what we need in terms of medication, and even if we need to go to other stakeholders, once we have this website, it will help us go a long way. So additionally, in terms of the hope and help, we're hoping to collaborate with doctors. So we have collaborated with some doctors, but this is an ongoing process to collaborate with more doctors from different hospitals, because Zimbabwe is very big, and I'm thinking there are other children in different spaces of the country. So we need to put posters. We have succeeded in 5 hospitals to put posters and flyers so that it's easier to diagnose CAH. And we've sought the help of the endocrinologists this side. They've been very helpful to help us chart how the doctors can attend to adrenal crisis. So another hope and help we have is seeking cheaper access to medicine. So again, Klein has been very helpful because they managed to give us, to assist us with 3-year supply of medicine, that's hydrocortisone and fludrocortisone. And this helped us in a big way, because if you look at how much this it was literally at no cost to us as Zimbabweans. But Clan managed to bear the cost for us, and we really want to thank them for that. So we are still trying to look for other more sustainable means of getting the medication. Thank you. Nicole, we can move on to the next slide. So in terms of hope and help, we're also hoping to collaborate with the government through the Ministry of Health. This is one ministry that will be able to help us significantly if we manage to collaborate with them. So that's in the pipeline. And we also advocate to schools. This is our hope that children will be able to know about CAH in these schools, that even our children will be comfortable around their peers. I've often said if I'm to be told to come to the school and talk about CAH or anywhere else, I'll be very grateful to go and talk about it, because this is a condition that people live with and it's part of us, and it's genetic. So it's just that people don't know much about it. So advocating that way would really help. And also advocating in the rural areas. There are so many children, I believe, in the rural areas of Zimbabwe who have CAH, but because they have no access to channels of communication. So I'm hoping that through community radios, the information about our trust, about what we can do for them, can get to them so that they can bring their children, or we can go to them and help them and teach them about what they can do to help their children live better. And also in terms of disseminating information, we've been using varied channels. WhatsApp has been very helpful because everybody has WhatsApp here. And most of the people, in terms of communicating, they communicate through WhatsApp. So I send material, the material I get from Clan. I also share with the people around stress dosing, around all those other issues, around what they can do when they have with their children with CAH. And it's amazing the number of questions that I get, but it's exciting because I love CAH. It's a part of me now. I often tell people that I am the one with CAH because that's how much I love it now. Thank you. So Nicole, we can move on to the next slide. And in conclusion, as a woman, I aim to amplify the voices of the children with endocrine disorders, invest in their initiatives, and create a world where every child has the opportunity to thrive. And lastly, my ambition is to open a center where these children who are affected can come for free or subsidized service. I actually want to bring an environment where those things where I needed, the resources that I have, that I thought I would need when I didn't have them, are easily accessible to all the parents, to all the children. So including cares, they will have Clan, they will have our website. It should be limitless for them. It should be available for them, because what I appreciate was the people who have accepted me, who have accepted my community, didn't say, no, you can't have this information. They've availed so many resources to me, and I want the same thing to happen for the community in Zimbabwe. And we can move on to the next slide, Nicole. Thank you very much.
Thank you so much, Harriet. So next I'd like to introduce Esther Koval. Dr. Esther is a dedicated pediatrician, child health advocate, and head of programs at Clan Child Health Africa. With a deep passion for improving children's health and well-being, she tirelessly champions children's rights and health equity. She collaborates with Clan Child Health Africa's partners regionally, as well as with local organizations to support programs that benefit vulnerable children. Driven by the belief that every child deserves quality healthcare and the opportunity to thrive, Dr. Esther remains committed to creating a brighter future through her advocacy efforts.
Thank you, Nikki, for the introduction. I guess I will be pardoned not to put my video on because it will affect the quality. But I'm going to be talking about how we empowering families in Africa, children living with NCDs, to move from struggling to having, strength to be able to handle their children. Next, Nikki. So this was just briefly about myself, but I guess we can't skip that because Nikki has really said a lot about me. I will just move on to talk about my personal motivation and what drove me to, do this work, working with NCDs. So there are three main things, really, my medical background and being a pediatrician. I've had the chance to really, work with children who are living with NCDs and their families. And I have, witnessed firsthand all these challenges that these families go through in trying to manage these chronic illnesses, whether it's sickle cell, it's congenital heart disease, it's CAH, epilepsy, mention them all. And I see that beyond the medical complexities that these families go through, there's a lot of emotional, there's a lot of social, financial burdens that these families face. And seeing them go through this has really fueled my passion, not just to provide clinical care to them, but also see that I advocate for better support systems that will empower them to see that they have long, good outcomes for their children. The other thing that drives me is what the resilience that I see among the parents, the children, their caregivers. And I see that even if these families are facing these lifelong conditions, they have this remarkable strength in trying to navigate our healthcare barriers, especially here in Uganda, in Africa, and the burden that comes with the treatments, the social stigma associated with all these diseases. Seeing them go through this has really inspired my commitment to see that I provide holistic care for these families, see that these children receive optimal medical management, and that their families are really equipped with the knowledge and the resources that they need to be able to support their children well. And my the last thing that I see is the passion that I have to be a catalyst for change. I believe that every child that I see deserves a chance to have a fulfilling life, regardless of their condition that they've been diagnosed with. And for me, I want to see that if I can be able to bridge the gap in care, be able to amplify the voices for these families, and make into interventions that can ensure that these children can, with NCDs, are not only surviving, but they are also thriving in our current community and the current situation that they are in. Over. Next, Nikki, thank you. So when we look at the burden of NCDs in Africa, particularly, before it was believed that NCDs was traditionally a problem for people in the developed world, but in the recent times, we've seen that these NCDs have also become such a growing public health challenge for us here in Africa, and they're really contributing a lot to morbidity, mortality, even just disability for the children we see. WHO shows that 37% of NCDs in 37% of people in Uganda are suffering from NCDs, and it's contributing to significant numbers of deaths. And yet this is a figure that continues to grow so much higher than we see. And yet, despite this growing burden of NCDs, access to universal health care still remains a big, big challenge for us. I cannot say more about how these challenges exist. The previous speaker, Harriet, has very rightly articulated the challenges that the children are facing. And this is not just in Zimbabwe, but this story is what we are seeing in Uganda. It's the story that our colleagues are seeing in Kenya, in Tanzania, in most of our African countries. So we see that all these challenges are many, and we need to, help our children to be able to thrive despite all these challenges. Next, Nikki. So to save time, I'm not going to talk about that next slide because it's basically what Harriet has been talking about, the challenges in access to medication, the tests, the stigma that is associated with all these diseases. So I'll just move on to the next slide and briefly share with you some of the lessons that we have seen and achieved working with these communities. When I talk about community engagement and empowerment, we've had a chance to work with parents of children who have epilepsy. Epilepsy is very common in Uganda, and yet there's a lot of stigma that is associated with the disease. And we have a chance to work with parents who, even in our own country, are really those who do not have resources to take care of their children. I know that I can assure you that most of the families we are working with are headed by mothers. They've been abandoned by their husbands, and the responsibility of taking care of their children is really relying on them. And yet most of these mothers that we are working with have had to leave employment to sit home and take care of their children. So they are really barely scratching off the surface. And we have brought these mothers together in a family support group, and they are helping one another. They are supporting one another emotionally. And it may not be financial, but whenever one of the mothers needs a little bit of support, maybe guidance on a better healthcare provider to see guidance on which facility they could, maybe seek a second opinion, they are getting this information from their own colleagues. And this has helped them also boost their confidence in taking care of their children. We've supported these families to set up an economic component so that we can reduce the financial burden. Like I said, we have seen these mothers have had to sit home because they cannot afford to work while they're taking care of their children. So we are supporting them to be able to set up business ventures so they can raise money just to be able to buy medication for their children, be able to, buy food, which is a basic need for these children. The other thing that we've done with community engagements is community awareness, education. We've talked to people, talked to the community. We've had awareness talks, shared the epilepsy rights flyer, which we basically adopted from a CAH flyer that was already existing. And we've shared material with these parents, and now they understand their children's illness a lot better. The second project that we are working on is a research in the area of CAH. CAH is one of the diseases that little information is known about in Uganda. And even when it exists, there's a lot of myth and misconception about the disease. So we're trying to see that we build first the capacity of our health workers just to be able to identify children with CAH, because our endocrinologists are only getting these children much later, 10 years of age, 15, adolescents. That is when they are presenting to the health facilities. So we want to see that we can empower our health workers to be able to identify these children early and then refer them for care. So that is a research that we are currently undertaking on building health worker capacity. The last is in leadership for NCDs. We understand that NCD is not a disease, they're not conditions that you can manage alone as an individual. You cannot manage alone as a single organization. So we are working hand in hand with the hospitals, partnering with the hospitals, partnering with other organizations that are already doing NCD work in these different areas that we are interested in working, and just trying to build on what is already existing so that we can make the work much, much more stronger. We also work with the Ministry of Health, trying to influence development of guidelines, also enforcing this training of the health workers capacity is all work that we are doing with the Ministry of Health. Over to the next slide, Nikki. I just would like to share some of the stories that I've had from the parents. When we sit with them during meetings, I did not know that I was doing anything. I did feel the impact of the work that we're doing, but when I had one of the mothers tell me, she shared and said, I am currently unemployed. I had to leave my job when my son started getting convulsions. I have been struggling to get money just to buy medication for him. But now with this business that you have helped us to start, I can see hope. I now know that I'll be able to buy my child medicine. And I now see that I will also be able to have money left over to buy for him the food that he loves to eat. So it was a small thing that we're doing for the community, but the impact that it had on this mother was tremendous, and it just gives us the drive to keep moving and keep pushing on. Over to the next slide. So this is briefly to share with you where we are and what we have done as Planned Child Health Africa. The communities that we are working in are the epilepsy community, the sickle cell disease. We're doing some awareness drives with the sickle cell community. We are working with the community in cerebral palsy, training mothers on how to take care of their children, and in CAH. And we have been able to successfully set up a family support group for parents of children with epilepsy, which we hope to launch on this end of this month on March Purple Day celebration. And we are also going to launch we launched the epilepsy rights flyer last year, still during the March celebrations for Purple Day, which was the day when we finally had a chance to interact with the parents for the first time on a big scale. We created a video that highlights the plight of sickle cell in Uganda. Kate has a copy of this video and it will be shared in the work. So far, we've seen more than 20 parents of children who are living with epilepsy that we've been able to directly reach, that we've supported with the family support group. Their knowledge has improved on how they take care of their children, and also their understanding of their children's diseases. And I'll talk about the partnerships that we've had. The community has been our biggest allies. They are committed to seeing a change in their children. We've worked with the hospitals, the health workers, the people in the government have been very helpful in Ministry of Health, but also other civil society organizations that help us to reach many more people. We've shared the epilepsy rights flyer, for example, with some of these organizations, and they keep sharing them with the communities where they go. Next, Nikki. So I'll just talk about my personal reflections working with these children with NCDs. And I will say that for me, working with these children has been a period of learning, empathy, and unwavering commitment to be able to deal with these children. And I see that for every child that I work with, I look at them beyond their diagnosis. Whether I'm dealing with epilepsy, whether it is sickle cell, whether it is CAH, these children have dreams, they have talents, and they have the desire to be seen, and they have the desire to be valued. So I tend to want to look beyond their medical illness and appreciate the importance of fostering a sense of normalcy, ensuring that these children are not really defined by their opportunity, but they are given their condition, but are given an opportunity to thrive. The other thing that I would like to think about, that I think about so much, is the strength of these families. They are a source of inspiration because the journey that they undertake, taking care of these children, is not a journey that you can take alone. And I've been moved by their resilience to take care of their children. Despite having the limited resources, they still dedicate themselves wholeheartedly to see that their children have the best in life. And I've seen many of the parents we work with become advocates for better health. I've seen them educate, so they they educate other caregivers. As they go to receive their routine visits, they talk to other parents and encourage them. These are parents who have become better nurses for their own children at home. And they've seen that they've helped their children to be able to adhere to their medication better. It has improved the outcome in some of the children who are attending our support group. And they need to advocate for these NCDs generally. We see that most of the heartbreaking things I have seen working with these children is witnessing the stigma and the social isolation that these families have to endure. I've seen children being excluded from school because of their conditions. I've seen many of their parents being blamed, especially the mothers are often blamed for their child's illness. And these families tend to struggle a lot with discrimination. So I want to see that I can not only provide their medical care, but also advocate for them to be included within the communities and where they come from. So, and lastly is personally my resolve for growth. And I see that every child that I have treated as an individual has left an imprint on my heart. They've shaped me to be a little more compassionate and more determined in my advocacy for better child health. It's been both challenging for me working with these children, but it's also been very rewarding, and it pushes me a lot to think beyond this clinical work that I do. It has reinforced my beliefs in not just treating diseases, but improving livelihood, supporting families, and ensuring that we support every child reach their full potential. So over to the next slide, please, Vicky. So I just want to leave you with these two thoughts. Addressing NCDs in children requires a multi-sector approach that we already know, but it goes beyond just their medical treatments. We need to think a lot about the emotional, the social, and their educational support systems as well. And we see that with the right support, children with NCDs can thrive. They can pursue their dreams, and they can continue to be very meaningful in society. Thank you for joining my talk, and over to Nikki.
Thank you so much, Esther. Next, I'd like to introduce Dina Matos and Alyssa Late. Dina Matos has led the CARES Foundation as Executive Director since 2009, advocating for individuals with congenital adrenal hyperplasia. She co-developed the catalog registry, supported the PACE app, and co-hosts the CAH Pulse podcast. A founding member of CAH International, she has volunteered widely in healthcare and received honors including City of Hope's Woman of the Year and the Cancer Institute of New Jersey's Award of Hope. Alyssa Late is the daughter of Kelly Late, founder of the CARES Foundation. She continues to support the foundation's mission, advocating for individuals with congenital adrenal hyperplasia and promoting awareness and research for better care and treatment.
Hey everybody. All right, well, I'm going to jump in with a little story to set up Dina. And I don't have any slides because this is really just a story and history of CARES and of the impact of my mom, Kelly. So my name's Alyssa Light, and I have non-classical congenital adrenal hyperplasia. I'm here today to share how one mother's determination inspired a community and created global change in health outcomes for countless children and adults. When I was just 4 years old, my mother, Kelly Light, noticed something wasn't quite right with me. She took her concerns to my pediatrician, only to be dismissed. Year after year, as my symptoms progressed, she was repeatedly told everything was normal. But like many mothers can attest, she had an instinct that something wasn't quite right with me. Unfortunately, it wasn't until I was 7, years after year of persistence, that the doctor finally agreed to run some blood work. The results revealed extremely high androgen levels and irregular hormone patterns. These were clearly abnormal for a child my age, and something was indeed wrong. So at that point in time, my mother began searching for a pediatric endocrinologist and fortunately found her way to Weill Cornell Hospital in New York City. Upon reviewing my blood work, the doctor immediately referred us to Dr. Maria New, who at the time was the foremost specialist in CAH and the pioneering researcher who first identified the non-classical variant of the disorder. While grateful for a diagnosis, my mother felt very afraid and alone with very little information at the time about CAH. Thankfully, Dr. New had built a substantial cohort of CAH patients and connected my mother with other families, parents, and affected adults. This was in 1999, so the internet was just becoming an emerging and powerful tool. My mother was very lucky to utilize this new technology to create a website. This was very big deal at the time, bringing together the CAH community from across the country to share experiences, knowledge, and much needed support. In early 2000, the CARES Foundation was officially launched with a mission focused on CAH, support, education, and research. And by the end of that year, the first newsletter was published, which shared CARE's vision and mission for the future. In the late 1990s, early 2000s, knowledge and research on the treatment of congenital adrenal hyperplasia was extremely limited. My mother often felt lost in figuring out the proper treatment for me when the current methods weren't working, a challenge shared by many parents and individuals affected by CAH during this time. This inspired the CARES Foundation's establishment of a medical advisory board with doctors specializing in varied aspects of CAH treatment from across the country. In 2001, CARES and Weill Cornell Hospital co-hosted the first educational conference on the treatment of CAH, which evolved into an annual event hosted by hospitals throughout the US. Simultaneously, the technology for newborn screening was expanding rapidly, allowing for many more genetic diseases to be screened at birth than ever before. My mother recognized this as an opportunity for CARES members to advocate for comprehensive newborn screening that included CAH. Utilizing this network of members across the US, they were able to get legislation passed to expand newborn screening, including CAH, in all 50 states within 9 years. An extraordinary achievement that enabled CAH to be detected at birth and these babies to receive proper treatment earlier, saving the lives of countless children across the country. Now, 25 years later, the CARES Foundation continues to make a growing impact, demonstrating how one mother's love and unwavering dedication can truly create global change. In 2009, my mother retired from CARES, passing the torch over to Dina, who has continued to advance this vital mission. I will now turn it over to her to share more about her efforts and the remarkable work CARES had done over the past 15 years. Thanks so much.
Thank you, Alyssa. It's great to share the stage with you. My name is Dina Matas, and I'm the Executive Director of CARES Foundation. I am honored to share this virtual stage with so many remarkable leaders. Women have long been at the forefront. Nikki, go ahead. Sorry. Women have long been at the forefront of creating change in healthcare, driving improvements that have global impact. From grassroots organizations like CARES Foundation to large-scale health initiatives, Women play a pivotal role in shaping healthcare systems, ensuring access to care and advocating for better outcomes, particularly in underserved communities. As Dr. Gro Harlem Brundtland, former Prime Minister of Norway and Director General of the World Health Organization, said, "Health is a human right, not a privilege, and women are a driving force in making sure that it is delivered to all." Her work in global health has emphasized how women's leadership and advocacy can elevate healthcare systems on a global scale. Next. One such inspiring figure is Dr. Agnes Bainwaho, a Rwandan pediatrician and former Minister of Health. Through her leadership, Rwanda significantly improved its healthcare infrastructure, including the reduction of child mortality rates and the implementation of universal health care. Bainwago's efforts serve as a testament to how women can transform healthcare systems, especially in countries recovering from conflict or facing substantial healthcare challenges. Another example is Dr. Florence Wangangi, the Chief Administrative Secretary of Health in Kenya, who has been instrumental in improving healthcare access, particularly maternal and child health in her country. Her leadership showcases how women in government can effectively use their platforms to improve healthcare systems, ensuring that policies are inclusive and address the needs of all communities. Next. Furthermore, the late Dr. Mary Lasker, an American philanthropist, was key in organizing public health campaigns in the 20th century that raised awareness and funding for cancer research. Her work led to the establishment of the National Institutes of Health's National Cancer Institute, demonstrating how women, even beyond direct healthcare work, can influence policy and funding to tackle health crises on a global scale. Next. These women, among many others, like many of you here today, exemplify the strength, resilience, and ingenuity that women bring to the global healthcare landscape. Their work not only highlights the transformative power of women in shaping healthcare, but also underscores the importance of inclusive, diverse leadership in achieving sustainable, equitable health outcomes for all. In 2000, as you've heard, CARES Foundation was founded by another visionary woman, Kelly Light. Over the past 25 years, we've reached numerous milestones that I'm excited to share with you today. The first initiative was newborn screening, a program that has saved thousands of lives. CARES Foundation was a catalyst for adding CAH to the newborn screening panel. Through our grassroots efforts, every state in the United States now tests newborns at birth. And newborn screening programs in the U.S. refer parents of newly diagnosed babies to CARES Foundation for support. CARES has also assisted other countries in advocating for comprehensive newborn screening for CAH. Next. CARES serves as a resource for patients and caregivers who are looking for doctors with expertise in treating CAH, a rare condition that is not well understood by many medical professionals. We work with members of our community to ensure that they are connected with medical professionals who can address their unique needs. CARES Foundation provided seed funding for the National Institutes of Health's CAH program, which is conducting the largest natural history study of CAH. Next. Patient and caregiver education is a crucial part of our mission. In our 25-year history, we've reached thousands of patients and families through our education conferences, webinars, and through our podcast, CAH Pulse. These programs have educated not only patients and their caregivers, but also researchers and other medical professionals about the complexities of CAH. Next. With 40 support groups in the US and 12 abroad, we offer guidance, shared experiences, and hope to many who face the daily challenges of living with a rare condition. Individuals living with a severe form of CAH are at risk of adrenal crisis during times of illness or injury. However, emergency medical services in the United States often do not know how to handle these emergencies. CARES embarked on a campaign to advocate for better care in an emergency setting by educating EMS professionals and requesting that ambulances carry the life-saving rescue medication. Next. Because newborn screening has saved the lives of many CAH patients, those patients are now living into their 50s, 60s, and beyond. Therefore, the need for continuity of care is greater than ever. So CARES Foundation assembled a group of the world's leading clinicians, patients, and caregivers who were instrumental in developing guidelines for the development of comprehensive care centers, or centers of excellence for CAH. There are now 9 centers of excellence in the United States. Next. Patients and caregivers can receive guidance from our medical experts via our online Ask the Expert service. This service is available in English and Spanish and provides guidance as well as peace of mind to those who have questions about their treatment, medications, or need a second opinion. The PACE app is an application on a mobile device that includes information on stress dosing during illness or injury and steps to take during an emergency, including a video on how to administer the life-saving injection. The app is available in English and Spanish. CARES has been actively involved in supporting research for CAH, including funding studies and recruiting patients to participate in clinical trials. This work has contributed to the first new treatment for CAH being approved in more than 70 years. What started in a small state called New Jersey, represented by the small dot on the map, you'll see the next slide, has reverberated throughout the globe. CARES now serves more than 8,000 patients and families all across the United States and in more than 80 countries and territories. There we go. We started right there where that little arrow is. Next. We have accomplished much in our 25-year history, but there is much more work to be done in support of CAH patients and families all over the world who rely on leaders who have the courage to change the course of history. To all the women who think they cannot turn a personal challenge into a global mission to change lives, CARES Foundation is proof that you can. Thank you.
Thank you so much for all the work that the CARES Foundation has done and all the work of Dina, Alyssa, and Kelly. Very inspirational. So now I'd like to introduce Dr. Paola Duran. Dr. Paola is a pediatric endocrinologist from Pontificia Universidad Javeriana. And she's the chief in pediatric endocrinology at Cardio Infantil Foundation and the director of Siendo Foundation in Bogota, Colombia. A dedicated educator and Mates for Kids member, she collaborates with the Global Pediatric Endocrinology and Diabetes, GPED, and others to advance care for pediatric endocrine disorders. Passionate about health equity, she works to improve access to quality care for children in resource-limited settings.
Thank you, Katie, and thank you so much for the opportunity to be here sharing with you today. We will talk to you about the achievements we have done for the CAH community in Colombia. Next, please. So my team and I come from Colombia, which is a country in South America with a population over 52 million. It is an upper middle income country. Next, please. We have been collaborating and growing thanks to the Clan Foundation and AdMates Community for Kids. We have already talked about it, so I'm not gonna spend more time talking about AdMate for Kids. Next, please. So we began working on March 2023, and I'm going to tell you a little bit what we have been doing and where we are now. So we started in March 2023 with the Clan Snapshot Survey and to understand Colombian pediatric endocrinologists' perception of the morbidity and mortality experienced by families and children living with CAH in Colombia. We had the participation of 78 out of the 80 pediatric endocrinologists in Colombia, which is 97.5%. And that was one of the instruments we used. Then in July 2023, we did the GPED survey in Latin America through the Latin American Pediatric Endocrine Society, but I'm only going to talk about the results in Colombia. And this survey, the aim was to identify the inequities in access to medicine for children living with congenital adrenal hyperplasia and also newborn screening. Next, please. So the main results in these surveys were that fludrocortisone, the perception of the pediatric endocrinologist was that fludrocortisone was available 100% of the patients, and 75% of the ped endos thought it was available to 33% of the patients free of charge. The oral hydrocortisone was 97% available, and also 75% of the ped endos thought that it was available 33% free of charge. The IV hydrocortisone is only available in hospital. It is not available at home, but in hospital it was available 100%, and 100% of the ped endo thought it was available free of charge to 60% of the patients. Regarding the newborn screening, the perception was that it was available to 48% of the patients at a national level free of charge. Next, please. In March 2024, we did the first CAH club meeting in Colombia. We did not have a community of patients or families in Colombia. We were very happy to receive all the messages of support from many of you. Thank you very much. And also, we also had a grant from Clan that helped us a lot to do this club meeting. And we did the health need assessment survey, which was also provided by Clan and was tailored to Colombia. There were 111 assistants to this club meeting, 32 families, and the 32 families completed the survey. It was transcribed to RedCap platform, and we obtained the ethic committee approval. And we used the 5 pillars of Clan to do the analysis. Next. So the main results were that there was a system deficiency because 90% of the families use a quarter of their income for treatment and hospitalization in a country where it was said that there was a coverage of health in about 99% of the patients, but the coverage is not complete. There was a lack of education. Less than 50% received information regarding the condition from their doctor, and they all received the education mostly online. And the major difficulty that was found, it was the access to quality healthcare and education. Next, please. So a great thing happened. It was that the first CAH community was developed in Colombia, and it is growing, and it is working, and it has an Instagram now with 103 followers. It also has WhatsApp because it's also a mean of communication in Colombia that is very widely used, and we will have some leaders of the community talk to us in a little bit. Next, please. Then, since we had the health need assessment, we used the check score also provided by CLAN. As you know, the check score, if you get a lower score, you have a greater chance to thrive. But if you have a high score, your survival is at risk. So we applied the check score to the 32 families, and thanks to that, we were able to identify 7 families that were very vulnerable. And living with CAH was 21.8% of the families. Next, please. So what we did next was to call each of these family and do a personal interview to find out what their major concerns were. And we found that even though education was a major concern in all the families, these families that were very vulnerable, only one had the concern of education, because they had so many other concern and greater concern that education was not one of the biggest one. But transportation and food expenses was the major concern found, and also finding a medical appointment. So even if they had a medical appointment, it was very difficult to come to the appointment. So we did a field research, and we consulted over 30 providers to establish what would the subsidy was like, so we could give it to the families and they could come to the appointment and eat when they were during the day they were in the appointment, because they said that when they could pay for transportation, they would have to spend the whole day without eating in order to get to the medical appointment. And also we help find the medical appointment. Next, please. So our progress based on the CLAN strategic framework, we have used the 7 the tools that CLAN has generously provided. And the progress we have seen with that is that we have now a community, and we have, if we look at the first pillar, community development, we have a Colombian nonprofit organization. We have identified the community leaders, and we are helping build community platforms for those for the CAH community. Next, please. The second pillar is affordable access to essential medicines and equipment. So we gather some data through CLAN and GPED survey, and we are now working on national registry so we can continue to work on that. Education, research, and advocacy. We now have education material in Spanish that has been provided to the community, and they are using it, and they are it has helped a lot. And we also had multiple meetings with the families and provide information and resolve doubts with them. Reducing financial burdens and promoting financial independence. So as I already said, we are supporting 7 of the most vulnerable families that were found using the check score. And we have an ongoing work to identify these vulnerable families and to be supportive. And optimization of medical management. I will only say one of the things that we have been doing, but in Colombia, the newborn screening was approved in 2019, but had not been implemented. By advocacy and by working together, it was implemented in July 2024. We are now working on tracking how is it working, how many children are being diagnosed, and how many lives are being saved by the newborn screening. Next, please. So our main challenge right now is that since the time these surveys were conducted and designed, the Colombian healthcare system has changed substantially, because we are having a political situation, and the health system is changing. And today we have a very different reality with greater challenges and uncertainty, but we are working all together to overcome these challenge that we have right now. Next, please. I would like to thank and acknowledge all the key partners. We have been working together, and thank you very much. And next one, please. If you would like some more detailed information about how we did the club meeting and what happened, you can have the information in this QR code, and also you have the video of that day that you can find in YouTube. So I would let now one of the leader of the community, Angela, talk, and she will tell us the progress that the community has done and how they have been growing. Hello, Angela.
Hello, hi, my name is Angela Castro. I am one of the leaders of this beautiful community. Next, please. Who are we? We are the first HSC community in Colombia and Latin America, consisting of mutual support and training. We are present in social networks with an exponential growth. We promote an open, respectful space where we share experience and knowledge. We have the opportunity to learn, connect, and contribute to improve to our quality of life, building a solid support of network. Together, we are stronger. Our progress. We create an online library with books and articles for permanent consultation, virtual trainings with health professionals to provide information and answer questions, and training recorded in order to video clips and share teams on our social networks. Next, please. We create two printables, emergency protocol and medical recommendations, academic and care. We are new cats with the new bulletins and inspirational stories. Individual emotional support, a space to share experience and create strategies. We collaborate with other orphan disease for patient foundations to increase our visibility. We participate in training and recreational meetings of their foundations to provide us with feedback. We follow up cases of denial of health service and generate strategies for solutions. I leave you with my mother, who is a leader of the community and who has been a great support for me in my process and the process of creation and progress of the community. Wow.
Buen día para todos. Quiero iniciar esta presentación agradeciéndole primero a la doctora Paola Durán por todo su apoyo incondicional con la comunidad.
She says hello, and she would like to start thanking the support that we have given the community with the Ciendo Foundation to grow and to be created.
El camino no ha sido fácil, pero sin su ayuda y sin la ayuda de la Fundación Ciendo, no hubiéramos obtenido los logros que tenemos.
It hasn't been an easy path, but we are certain that we can continue and we will make a great job.
La motivación es diaria. Nuestra misión es lograr que a través de nuestras rutas de acción podamos mejorar la calidad de vida de los miembros de nuestra comunidad.
We have a daily motivation and we work every day to get a better quality of life of each member of our community.
A continuación vamos a ver 4 historias de 8 que hemos tenido de éxito gracias a la comunidad.
Thanks to the community, we have had 8 success stories. I will share with you 4 of them. So I will tell you the stories that Sandra and Angela have shared with us. So the first one is Jody Esperanza, which is very happy because she says that she felt alone fighting an endless battle. And thanks to this community, she's not longer feeling alone. Paola Bravo, she lives in the coast of Colombia near Cartagena, and she was feeling she couldn't handle the situation anymore, and the community, she says, the community helped me to move forward. And Emel Silandero says that when she felt defeated, the community provided the support and helped her be stronger and feel better. And Wendy Sandoval says that in a moment of weakness and frustration, I felt the shelter and support of all the members of the community. And she wishes that they continue to strengthen this bond. So this is some of the stories that we wanted to share with you today. Thank you very much for the space and for having the opportunity to share with you today. And thank you, Angela, for being here and for talking to us. You did a great job.
Thank you.
Thank you so much, Paola and Angela, for your great input. It was very touching. Next, I'd like to introduce Jeff Cogdandahan and Ellie Rubashkin. Jeff Cogdandahan is the president and co-founder of Intersex Philippines and co-chair of Intersex Asia. A trailblazer in intersex rights, he became the first intersex Filipino legally allowed to change his sex marker in 2008. He plays a pivotal role in advancing the intersex rights across Asia, working to promote visibility, inclusion, and legal recognition for the community. Ellie Rubashkin is the cross-movement building officer at Intersex Asia, with a background in pharmaceutical sciences and intersectional human rights advocacy. Committed to expanding intersex rights, Ellie works to advance policy reform, healthcare access, and community capacity building through empathy and strategic partnerships. Their efforts focus on increasing visibility and protection for intersex individuals across diverse movements and regions.
Thank you, Nikki.
Thank you. Thank you,
Yeah.
Nicole.
Yeah. Honored guests, colleagues, and fellow advocates, mabuhay. I'm beyond grateful to be here with all of you today as the co-founder of Intersex Philippines, a proud member of Intersex Asia.
Can you give me what
And a person, can you again, next slide please, thank you. Okay. Again. Honored guests, colleagues, and fellow advocates, mabuhay. I'm beyond grateful to be here with all of you today as the co-founder of Intersex Philippines, a proud board member of Intersex Asia, and a person living with congenital adrenal hyperplasia, CAH. For too long, children and adults with CAH in the Philippines and across Asia have faced preventable sufferings. Suffering that stems not from the condition itself, but from systematic barriers to healthcare. Today, I am here not just an advocate, but as someone who has lived this reality. I speak for every parent. I speak for every parent who has held their child through an adrenal crisis, for every individual who struggled to access life-saving medications that should be a basic right, not a privilege. In the Philippines and many parts of Asia, access to medicines like hydrocortisone and fludrocortisones remain inconsistent, unaffordable, or simply unavailable. This is not just an inconvenience. It is a life or death issue. Without this medication, adrenal crisis occur, leading to unnecessary hospitalization, complications, and in too many cases, premature deaths. Through our work at Intersex Philippines, Intersex Asia, and CASAPI, we have spoken to families who have lost loved ones because treatment was out of reach. We have seen children's lives upended due to financial barriers that should never stand between a person and the care they need. Yet, despite these challenges, we also see hope. Through our current collaboration with CASAPI, CLAN, Cancer Warrior Foundation, Philippine Society of Pediatric Metabolism and Endocrinology, through Dr. Jadine Aragon and the broader regional collaboration of Intersex Asia, we are actively working to bridge the gap between movements and the care our community desperately needs. This means advocating for policy change to ensure that hydrocortisone, fludrocortisone, and emergency adrenal treats are included in national health programs, including those associated with newborn screening. Partnering with orphan disease organization to strengthen advocacy for CAH, collaborating with healthcare professionals to improve medical training and awareness, ensuring that CAH management is accessible and affirming of life. And lastly, engaging with affected families to provide support, raise awareness, and amplify their voice in decision-making spaces. This work is not just about access to medicines. It's about affirming that healthcare as a human right should be realized. Access to technologies associated with diagnosis, effective monitoring such as 17-OHP test to name one example, as well as compassionate healthcare providers aware of this condition and willing to help these communities in times of medical emergencies. Our goal is centered in ensuring dignity, access to basic life-sustaining treatments, bodily integrity, and access to health care that respect the lived experience of those it serves. We cannot do this alone. That's why we call on governments, allies, feminist movements, children organizations, pharmaceutical sector, and global health bodies to take immediate action and work with us in helping us identifying ways to overcome these systematic barriers by, first, make life-saving medication affordable and accessible. No more stock shortages, reimbursement mazes, no more price barriers. Second is to ensure newborn screening and early intervention program integrate emergency kits in newly diagnosed CAH infants so that no child is left diagnosed or improperly treated in case of adrenal crisis emergency. And lastly, recognize CAH medical needs in access to medicines as urgent public health priorities, integrating them to universal health care systems. To our allies in the healthcare sectors, we hope to work collaboratively to identify our communities can see in your efforts a life-affirming partnership in the shared goal of saving CH children's lives. While we hope to avoid centering other debates about identity in social issues surrounding gender and bodily anatomy, we make a plea for urgent, affirming, and equitable healthcare solutions for all persons living with CAH, including male, female, and intersex persons. To the families here today, particularly the voices of mothers, your voices matters. Your advocacy is powerful. And together, we can illuminate the path for the change we so desperately need. I stand here today because I have been able to access the right care. While I experience daily the limitation of living with CAH, I have seen what is possible when healthcare is accessible, universal, equitable, and affirming. But too many in our communities are still waiting for that chance. We cannot wait. We cannot afford to wait any longer. Lives are at stake, and the time to act is now. Leave no child behind. Thank you. Maraming salamat po. And I'll pass it now to my colleague, Ellie.
Thank you, Jeff, for that wonderful speech. It's actually very soul touching, and I appreciate the work that you've been doing. I think it's very important I introduce myself more broadly speaking. This is my mom. I don't know if it can be seen. I think I have to remove my background blur. My mom is a pediatrician that studied in the Simferopol University in Ukraine. And I was born from this beautiful human being that worked in Colombia for 40 years, looking after the lives of children, including myself, and those like myself born not with congenital adrenal hyperplasia, but with androgen insensitivity syndrome, which was called differently at the time I was born. Being able to be here, and I think if you could please share the next slide. Being able to be here has allowed me to also reflect that we know the pain our moms go through, and we understand the pain that is caused by having to go on this roller coaster of life, dealing with a condition that is so poorly understood, even for a pediatrician, that is happens to also be a mom of someone that may have a particular endocrinological condition that is not necessarily very clearly understood. With my experience as a pharmacist, where I learned of the experience of Colombia, a country where deep gaps between lack of resources can be seen even for a person as educated as my mom, also experiencing the limitations of not being able to provide what these children need. With that frustration in my heart and the frustrations of not being able to express socially the ways in which I feel comfortable with myself, I went through the world trying to figure out ways in which I can provide affirmatively, with empathy and love, the work that this represents. And that's how Intersex Asia has came in this picture where so many of us, especially those that have lived in China or in Taiwan or regions of Asia, like myself, have been able to learn how we navigate the complexities of both trying to understand our medical conditions and at the same time building communities where that allows us to help each other and to help navigate some complexities that go beyond some medical issues. So in 2018, 14 intersex persons representing multiple communities from around Asia met in what was the first Asian Intersex Forum in Bangkok, Thailand. And I'm very happy to announce we just held in Kathmandu the 4th Intersex Asian Forum with more than 45 persons from many countries around Asia. And it was very impressive to see how this work is actually expanding in ways in which the visibility of these issues is helping our communities to understand where we come from and where we want to all of us go. Next slide, please. So Intersex Asia, most of the work we do is in awareness raising. There is not just CAH, that might be the most common intersex variation, or at least how we frame it. There are more than 40 other intersex variations and subvariations. And Intersex Asia hopes to bridge cultural gaps that exist between how these communities understand themselves, including cultural aspects in which intersex is often or sometimes perceived as an identity and not a medical condition. Also, movement development, which is something that very recently I started doing. I have not been in Intersex Asia for too long. I've been a couple of months. So part of my cross-movement work is actually to be able to be here and to share my knowledge with you and also receive your knowledge because I think it's an exchange that is required. Community empowerment, as I indicated, helping communities to be sustainable despite of the challenges that many of us are experiencing with funding. It's important to tell them how to fish, not giving the fish, I think is something like that, but at the same time, empowering them and giving them hope. And working on data and advocacy at the United Nations on violations on of human rights of intersex people, discrimination, violence, infanticide, and other gross human rights violations that are very prevalent in Asia. And as many of you or some of you know, in many parts also of the Global South and also even in the Global North. Next slide, please. So our community, as I said, is growing. I share here some of the images of some of the experiences in the Philippines with mothers that, thanks to the work of Jeff, were helped to be empowered so they can financially sustain the very expensive treatments that within the Filipino system is not covered by proper health insurance. And at the same time, in Kathmandu, we have the experience of being able to bring some of these persons living with various endocrinological conditions, many of these that lead to development and changes in the sex characteristics. So we had the chance to learn more about the Philippines from a Kathmandu community that also joined us. And I think we share a photo here with one of our greatest allies, which is Dr. Jadain Aragon, who's been doing this work actually almost as Dr. Kate has been doing this important work. So it is beautiful to see the smiles of hope in these moms. These mothers are the light of these children. And if these mothers can help themselves and their children, we can actually thrive and make that every single child is not left behind on their own. Can you please share the next slide? So among various things we have been doing, and this is focusing on the Philippines, we held last year in 2024 in June, a meeting with parents of children with CAH. And through this consultation, we came to elaborate a collective call for solidarity before the Department of Health, which is becoming a pivotal document that is guiding our attention or our work to guide the Ministry of Health or the Department of Health of the Philippines to find effective solutions, cost-effective solutions for these children, because it's a problem that despite the Philippines having advanced on MBS and also understanding orphan disease management, as we can call it, unfortunately, the CAH communities are still struggling quite a lot, and we are currently experiencing preventable deaths. And yeah, so I think I'm about to finish. Sorry for taking longer than I was hoping. So you can scan here and affirm the collective action, add your voice to our collective call. And next slide. And here you can, for those interested, access the preliminary evaluation where we evaluated the conditions of the CAH communities in the Philippines, and also the cross-movement strategy that we are framing in the Philippines, which is now being translocated to Nepal, which is a country that still requires more development of CAH communities and also intersex communities, but it's an ongoing work that, thank God, is going in very beautiful directions. I think that would be everything from my end. I'm very glad actually to complement my story with Colombia, the Colombian story that was just shared before our presentation, while at the same time, I want to acknowledge that I am in New Zealand, Aotearoa, where I live, recognizing the custodians of this land, the Native Fatwa people, the place where I live, and I carry the word for my community in Asia, from Colombia and from Russia with love, or like they would say, from Ukraine with love. So thank you so much, everyone. Thank you, colleague Jeff, Kuya, and thank you, Dr. Kate and Clan, for letting us be part of this conversation.
Thank you so much, Ellie and Jeff. So now I'd like to introduce Astrid Larasati. Astrid is a PhD student from the Universitas Niponegoro in Semarang Indonesia, specializing in congenital adrenal hyperplasia, disorders of sex development, and genetic counseling. Her research includes studying illness uncertainty in parents of children with CAH and co-translating a book for young women with CAH in collaboration with Mates for Kids and CLAN.
Thank you for the lovely introduction, Kate. I will introduce our collaboration project with CLAN and Mates for Kids, which aims to improve healthcare professionals' awareness about CAH newborn screening and management. Next slide, please. This is our team. Dr. Agustini is one of my supervisors. She's a pediatric endocrinologist and vice president of Global Pediatrics Endocrinology and Diabetes. She has been collaborating with CLAN and Mates for Kids to increase access to medicine and provide educational materials. Next slide, please. This is Professor Tri Indah Winarni, also known as Professor AIN. She's a geneticist and also one of my supervisors. She's a professor in genetics who has incredible work on rare diseases, disorders of sex development, single gene disorders, and many more. Our team works in one of the biggest congenital adrenal hyperplasia center in Indonesia that cares for a total of 162 CAH individuals. Next slide, please. Congenital adrenal hyperplasia, also known as CAH, is a group of autosomal recessive inherited conditions caused by enzymatic defects in adrenal steroidogenesis. Most of it are caused by 21-hydroxylase deficiency, which is characterized by various degrees of cortisol and aldosterone insufficiency and androgen excess. The global incidence, based on newborn screening data, is 1 to 14,000 to 18,000. Based on the CAH registry by the Indonesian Pediatric Society, there is a surging number of CAH cases from merely 56 females and 13 males to 303 females and 136 males in 2020. However, we face some challenges in diagnosing and caring for CAH individuals. Many Indonesian healthcare professionals have minimal knowledge of CAH, leading to misdiagnosis or delays in recognizing symptoms, especially in female infants with genital ambiguity. Moreover, CAH detection rates are low in Indonesia because in the past, there was no newborn screening for CAH. This delays diagnosis as affected individuals are often identified after symptoms appear. Some were discovered due to adrenal crisis. Therefore, CAH cases might be underrepresented. In addition, access to diagnosis remains limited because only a few medical laboratories that can measure 7-hydroxyprogesterone levels are mostly located in big cities. There is also no genetic laboratory in Indonesia which can analyze genetic mutations that cause CAH. Lastly, the BPJS, a government-provided healthcare insurance for Indonesians, does not cover the cost of genetic testing, hence patients need to provide a substantial amount of money. However, in 2024, a pilot project for CAH newborn screening started in several big cities on Java Island, the most populated island in Indonesia. This pilot project successfully screened a total of 30,000 newborns, in which 3 of them were detected as CAH positive. For 2025, CAH newborn screening has been expanded nationally. This is a huge opportunity because there are around 4.6 million babies born each year, and we can save hundreds of babies with CAH from developing lethal adrenal crisis or other morbidities. Next slide, please. Been collaborating with CLAN and Mates for Kids to increase access to medicine and provide educational materials for Indonesians. Both hydrocortisone and fluorocortisone are now available and manufactured locally and covered by the government-provided health insurance for all Indonesian citizens. IV hydrocortisone is also now available for emergency cases in the hospital and also covered by health insurance. In 2016, we published a book about an introduction to CAH for parents, the green book on the left side. This material could increase parents' knowledge about CAH so that they could provide a better care for their children and adapt well to the new situation. This material was also uploaded to YouTube to increase engagement and accessibility. We also made a CH website available at adrenal-indonesia.com, which contain educational materials for patients and healthcare professionals, including sick day management for parents and also adrenal crisis management for healthcare professionals. Next slide, please. In 2017, we made an illustrated book for young women with CAH. It has been made available in English in 2023 and also in Sinhala and Tamil in 2024. All thanks to Glenn and Mates for Kids and Sri Lankan pediatrics endocrinologists. Next slide, please. Our current work aims to improve healthcare professionals' awareness for newborn screening so they can be more prepared and also increase knowledge about the importance of knowledge of therapy regularity and also monitoring to ensure effective management. We will provide educational materials about CAH newborn screening, treatment, and monitoring in the form of booklets and videos. These materials will be uploaded to CAH website and also social media to increase accessibility, and also printed and distributed to healthcare providers. These materials are intended for both patients and healthcare professionals. Second, we will also conduct a webinar and online training for healthcare professionals, particularly midwives, nurses, and doctors, about CAH newborn screening and also the best practices and critical role of treatment and monitoring. We will be collaborating with a pediatric endocrinologist, a geneticist, and a clinical psychologist with CAH expertise to share their holistic approach. To increase participation, we will promote this program through the Indonesian Pediatric Society, Indonesian National Nurses Association, Indonesian Midwives Association, medical schools, and hospitals. We will also offer continuing medical education credits to increase engagement rate. Next slide, please. Thank you once again to Kate, Glenn, and Mates for Kids who have made this project possible, and to CAH communities from around the world for sharing such inspirational works.
Thank you so much, Astrid. Next, I'd like to introduce Durhan Wong. Durhan, a PhD holder, is a leader in the rare diseases field. She acts as president and CEO of the Canadian Organization for Rare Disorders, president of Asia Pacific Alliance of Rare Disease Organizations, and is the immediate past chair of Rare Diseases International.
Thank you very much. My huge thanks to Kate and to Glenn, not only for the invitation to speak today, but also for the opportunity to listen to all of these inspiring stories and the inspiring work that's being done. This is actually not going to be that inspiring from the point of view of personal experience, but I hope it does inspire you to join us in global action on rare diseases, of which CAH, of course, is a very important condition. So next slide, please. So I was asked to speak a bit about the intersection between rare diseases and the non-communicable diseases communities, and also to give you an update on what we're doing on our global advocacy, and certainly hopeful that you will join us in both our regional and global work. Next slide, please. So when you think about rare diseases, I think we oftentimes think about these very small patient populations, but really I want to do is impress upon you that what is rare is actually also common, and that for persons living with rare diseases, they actually are quite common across the many rare diseases. And I think you already know about it, you've spoken about it, I don't necessarily have to go into this, but I think what makes most rare diseases alike is the fact that there is in fact a great deal of stigma that's related to it, and discrimination, and obviously the lack of access to awareness, information, and the access to care and treatment. So you've already talked about this and what you're doing in your own communities. And this is probably true of most of the rare diseases that we're talking about. I think the other thing that's really important for us in the global community is that is, in fact, a lack of political awareness and a lack of strong advocacy to bring all the rare diseases into the healthcare system. So next slide, please. I think we're getting to the next slide. Okay, well, this is just a very quick thing. You've already talked about it. What does make rare diseases different from many common diseases is because there isn't, in fact, a rare, oftentimes awareness that the rare disease pathway, the journey, does not start in the way that most common diseases do, with a diagnosis, but often starts with a set of symptoms and then a lot of misdiagnosis before the person gets to maybe a proper diagnosis or to the proper care and treatment. So it's oftentimes a iterative route. But the other thing I want to say, and this really fits in with what I think he asked about, and that is rare diseases and non-communicable diseases. CAH, for as rare as it is about 1 of 7,000 rare diseases, and we're getting more and more added every year. 4,000 or so have an identified genetic cause, again, encompassing what you're talking about in CHH and many of these diseases. Interesting enough, there are about more than 800, maybe close to 1,000 drugs that have now been developed for rare or what they call orphan drugs. So this is absolutely a big breakthrough in terms of treatments. Next slide, please. Yeah, I think we have it here. Yeah. And this is kind of where we see the intersection of rare diseases and what we start to call in terms of subsets of common diseases. That is, a lot of the common diseases, as we're knowing, are actually, common diseases are things like cancer, stroke, dementia, TB, HIV, malaria, Ebola. These are the diseases that you would know as many of them infectious diseases, but also diseases that affect a lot of people and therefore get a lot of attention and often a lot of research and a lot of support. On the other lower corner, you will see is those diseases that affect very small groups of patients, including populations like CAH, which are generally neglected in terms of the kind of attention they get, both in the healthcare system, in the screening and diagnosis, but also in the development, research and development of new treatments. And then somewhere in between there, you can see on the opposite axis, is where we're getting rare diseases that are actually coming together in terms of clusters, but also common diseases that are beginning to be defined by very specific genetic mutations. Next slide, please. Which is why when we're saying that rare diseases in some respect are common because of the features that they share alike, what we know is that common diseases are increasingly becoming rare genomic mutations. So what defines CAH or other kinds of rare genetic diseases is also starting to define common diseases. So we know that cancer is not cancer, heart disease is not just heart disease, even some of the bigger diseases that we know of, things like Parkinson's disease or Alzheimer's disease, they're not necessarily one disease. In fact, there are many subsets of them, and they also then get as much ignorance in terms of specific diagnosis and treatment as do our very rare diseases. In fact, if we looked at all the genetic or genomic mutations of common diseases, we would be overwhelmed relative to the number of what we call unique rare diseases. So we know that 100,000 genomic mutations of cancer. So no such thing as just cancer anymore. More than 5,000 variations for some of the cardiovascular diseases, more than 1,000 variations for type 1 and type 2 diabetes. So diabetes is going to be increasingly, defined by different kinds of genetic mutations. And the importance of this, when we looked at especially the big category of neurodegenerative disease, is we can now do a whole lot more in terms of being able to treat them appropriately. Next slide, please. So for instance, we know that in many cases, we know that there are chemotherapies, there are radiotherapies, there are surgeries that's used for cancer oftentimes. But what we know now is if we can define them by specific genetic variations, we can actually do a much better job of treating them. And we can do a better job in terms of developing new therapies for them. This is just a list of some of the single gene tests that we use for cancer. I think most of you will know is that within breast cancer, there are many genetic variations. So instead of just treating breast cancer, we can treat a very subset of breast cancer if we get the diagnosis. Another exciting thing across this, when we look at multi-gene panels, is that the same genetic mutation can affect a whole variety of cancers. So you've got a common genetic mutation that may cause breast cancer, prostate cancer, lung cancer. And therefore, when you start to do diagnosis or develop treatments, you're going to be developing for the genetic mutation and be able to do clinical trials and treat a whole spectrum of diseases at the same time. Next slide, please. So as we say, we're increasingly getting targeted therapies for the mutations. We're getting targeted therapies, certainly in cancer. My husband, for instance, has Parkinson's disease. And what we know now is that all the treatments so far have just been treating symptoms. They've not actually treated the cause of the diseases. Now what we know is that if, in fact, we can identify what are the many different kinds of genes that are involved in Parkinson's disease, we can start to do a much better treatment. This is where the rare diseases are showing us the way in these common conditions. And the same thing with things that we talked about in cardiovascular disease and strokes, or as we said, even in terms of diabetes, which affects huge numbers of populations. But as we know, all we're doing so far is treating symptoms, which means that we're not really doing very much to identify those diseases early. We're certainly doing not very much to cure these diseases, and they remain in a tremendous burden of care on the healthcare system because there's so many people that are affected. We're not getting very far because, again, we're just treating symptoms. We're catching people after they get symptomatic. We're not able to catch them before these symptoms can occur or they're suffering severe disabilities. Next slide, please. So what we do know is that a lot of what has been fueling the development in terms of diagnosis of rare diseases, what has been fueling the treatment of rare diseases, are in fact incentives that have been given to develop drugs for rare diseases, really coming mostly out of the US, the European markets, or in terms of Japan. What we also know is that we're doing a much better job of being able to diagnose these conditions by being able to, as you're talking about in terms of newborn screening, but so far we have been limiting our screening to some of the known rare diseases, and we have not actually screened very much in terms of much more common diseases. We're also being able to do a much better job of being able to track people using what we call digital wearable devices, again, being able to collect information about persons who are living with these conditions to know much better what is it that stimulates certain kinds of symptoms or certain kinds of crises. Next slide, please. The big impact, I think, and the challenge I think we all feel is that because we are getting so much more information and knowledge about these conditions, we're going to be able to treat them better, but the challenge is going to be the impact on the economics. And I think this is something that I think you experience. And I mean, I work a lot across Asia Pacific. We've been, last year we were in the Philippines. We're going this year to be in Indonesia with our rare disease community, a couple of years ago in Thailand and in Malaysia. what we know is that the impact then on healthcare systems is tremendous, and economically, rare diseases oftentimes seems to compete when we're talking about treatments or we're talking about diagnosis with the more common conditions. As we get in the common conditions, they're also increasingly going to look for targeted diagnostics. There's a huge concern that we're going to be reaching truly an economic crisis in the healthcare system. I think we all know that there are more diagnostics, there are more treatments than most systems are willing to provide, even in high income countries. So the challenge will be, how do we make them available to everybody? Because we know if we can get to the diagnosis early, if we can do appropriate treatment, some of which can actually prevent serious disabilities, we're actually going to be saving monies. But how do we get the monies in front of the system so that we can do that kind of early detection and prevention? This is something that why we're working together with regard to universal health coverage, as you've talked about, but even within universal health coverage, needing to encourage the investment in terms of prevention and early detection as much as in terms of just treating the symptoms. Next slide. Globally, what we're trying to do, of course, across the many countries and the many diseases is to get people to work together. How can we do things that are more efficient, more coordinated? Not every country needs to do every regulatory review. Not every country needs to invest in all of the new diagnostics on its own. You've talked about what you're doing in CAH. Think about what that would mean then if we're able to do that across thousands of rare diseases, across many hundreds of countries that can work together and not have so many different systems that are needing to reinvent the same thing over and over again. And this is, again, our goal in coming together as Rare Diseases International. How can we pull that entire rare disease community together? Next slide, please. I would speak ahead, except I'm not sure what's on the next slide. My only waiting for the slides. One of the things I will say is that working in the Asia Pacific, the Alliance of Rare Disease Organizations, our biggest goal in working in this area is to really facilitate what you're talking about here, and that is regional collaborations. What we do know is that if we can get regions to work together, or as you're doing, having similar diseases that working together, we can actually do a whole lot more than if we're working alone. For us as well, within the Asia Pacific region, one of the things that we're trying to do here in bringing together some of the high-income countries, middle-income countries, and low-income countries is actually be able to share resources, share learnings, and in many cases, hoping to be able to share tools and technologies with the real goal, to recognize that, if we do not address those disparities, what we will do is, as we're getting more and more technology, as we're getting more and more high-cost therapies, we run the risk, and we're already doing that, of leaving the other countries and middle income as well as lower income countries farther and farther behind, unless there's a deliberate initiative to actually bring people together. And this is why it's so inspiring to hear the work that's Clan doing here, and the work that you're doing there collaboratively. Next slide, please. I think I'm almost done. So as we say, the challenges are really, within the technology, within the systems. The key is to actually work together and to do that much more. Go to the next slide, please. I just want to get to kind of where we're looking at some of the opportunities here. And working together globally, calling for the investment in public health, calling for the investment in preventive health. Okay, yeah, you can skip this. This just certainly shows again the challenges that we have in terms of disparities in healthcare. I mean, the big question we often ask is economic the only factor or the biggest factor? And the answer is yes, to some degree. It's a huge factor. The solution, again, is can we get, communities working better together and having a focus on equity for all persons. And this is, again, where I feel youth folks are saying it in SAGE, where rare diseases are saying it as well, and that is we are one community, and as we move forth with one community, we need to make sure we do not leave everyone else behind. And this is looking at some of the global policies that we've got. 2019, rare diseases actually got a political declaration on universal health coverage in which we identified rare diseases as a disadvantaged community. 2021, again, we got the UN to make a resolution on rare diseases, recognizing that it is not just a medical condition, but it's a social condition, it's a gender condition, it's a disparity condition, and that we need the investment across all of those spheres. 2023, we had a renewal on the political declaration at UHC. This is where we're coming to this year. We're asking the World Health Organization to put forth a resolution on rare diseases, which is even more impactful than the United Nations. Because if the WHO votes on this, the countries all vote on it, it means that they are committing to doing and investing in reducing the disparities that are experienced by rare diseases, but also investing in all the aspects of rare diseases, not just medically, but as I said, in terms of social and other economic disparities. Next slide. This year, I mean, as I said, our conference will be in Indonesia. I don't think I need to go into this very much. What we want to do is we want a global action plan. The global action plan, like the action plan for non-communicable diseases, calls on all countries to adopt the same principles. They may, in fact, be carried out in different ways, but it means that every country needs to set objectives and targets. It means that they will be held accountable to those. It also means that, to some degree, the WHO has to invest resources to help countries achieve these principles and to be able to carry out their action plan. Next slide. I mean, we feel very strongly that a global resolution will be benefiting certainly not too much the high-income countries, but really our low and middle-income countries, to bring in those countries into a global agreement, and it opens the room, as you know, for you to go to your governments and say, here's what we're doing, here's what we're advancing. You are now obliged, because of your commitment to a WHO resolution of rare diseases, to provide us with the support, with the financial support as well. Next slide, please. Oh, yeah, just thank you. I would just say clearly, you know, we are so grateful to the work that Plan is doing, to the work that you're doing. It's all the work on the ground, all coming together. I mean, if we can have 8,000, well, not really 8,000, well, let's say 2,000 rare diseases to work in the way that CAH is, I think we would have such a much greater impact. So we see you as an example of what many other rare diseases community could be doing and should be doing. So my huge thanks to all of you.
Thank you so much. Now I'm going to reintroduce Kate Armstrong to close out our session.
Thank you so much, Katie, and apologies from Carmen, my co-chair, and a leader in the childhood cancer space who can't be with us here today. But first, I just want to thank all of our incredible speakers. I've just been in awe. I've been pressing all my emoticons, going crazy. You've all been just incredible. So can't thank you enough. What an inspirational community we have here. Thank you all so much. Next slide. Thanks, Nikki. First thing that I'd like to say, actually, I might just go forward to the grants first, if I could, Nikki. I'm just going to share an announcement. I'm mindful we're out of time, so just want to firstly share that the round 5 grants are open as of today, as of this event. If you go onto the Mates for Kids website and go to the grants page, the round 5 grants are there. Especially CARES with your links to 80 countries, but to all of you, you know, the team in Africa, if you know of a country, a CAH community in a country that's really struggling, these grants are for you. They're not for high income countries, but we really are seeking to get to 40 countries by 2030. So please encourage people to reach out to these grants. So if I can go back to the 2 slides there, please, Nikki. I just wanted to briefly reflect on what I've heard from everyone today and go back to those 5 priorities that came out of the global review of the Beijing Declaration and the Platform for Action. We were aiming to elevate women's voices today, and I think we've done that in spades. Women, mothers, young people, community, hearing about the power of community. Today's just been inspirational, and I just really want to thank all of you. The power of the testimonials, I really want to, acknowledge even people who couldn't be here today, but the team from Colombia brought those success stories and brought those voices, and we could really hear it. And we really heard today that mothers are the primary caregivers. Closing the accountability gap, we heard a lot about that. Thanks to Katie, we're trying to hold ourselves accountable with our activity report. We've got to do what we ask others to do. So encourage you all to have a look at the activity report, and there'll be another one coming along soon, capturing all the amazing things that you're all doing. But from an accountability point of view, really looking at data, we've got the Mates for Kids indicators, and Columbia spoke about how they're using those. But really, as Derhan was just saying, about equity, 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 equity. And thank you to the high-income countries that are here, CARES in particular. The work that you've done to help us all is just incredible. The data we heard from Indonesia and from other countries, we're still hearing there are far more women, girls living with CAH than boys. And that gender gap is a reverse gap. Boys with CAH are just dying in huge numbers. And while ever we're seeing those gender imbalances, we know that we're still missing some children. Thank you, Alyssa. We love you. Love to Kelly. Thank you. Just on the next slides, then closing the financing gap. We've heard today about the importance of universal healthcare, around affordable access to medicines, but even innovative microfinance solutions like the team in Uganda are doing, offer us real hope for the future. Harnessing technology, we heard about the importance of newborn screening. It's not just cost effective, but it's an investment, as Derhan was saying. We heard about the WHO and how they're letting us use their CAP platform. That's technology. But also the team in Colombia were talking about websites, translations. Harriet was talking about WhatsApp. There's so many different types of everyday technology that we're all leveraging. And also we heard a lot about genetic testing that's available to rare diseases, but we know our colleagues in Africa and lower income countries, we just need to do so much more. How can we shock-proof for the future? I think newborn screening, we heard universal health coverage. We also heard, the existing tools and resources like the WHO's essential medicines list, the essential diagnostics list, but even some of those cross-cutting ideas, the multi-sectoral. We heard about the importance of schools from Harriet today. In terms of next steps, look, we'll be getting a report out. There'll be a video of today. We are very excited that our young people are holding an NCD, childhood NCD event at ECOSOC, and I'll ask Nikki and Katie to say something about that next. So please, support our young people. We really need to focus on access to medicines. We heard that so clearly today. We heard it from everybody. That needs to be our big key priority. We have formed a working group on that, and anyone who wants to continue working on that with us, please let us know. Bindon Farm from Pakistan, just yesterday in Nigeria, met with some of the leading doctors there. We're excited that there might be some options there, but we've really just got to tap into really important people at WHO, PAHO. We have to really explore some options. I think allies, partnerships, that really emerged in all of the presentations today about just how important these allies and partnerships are with ministries of health, politicians, with health professionals, with other NGOs, Intersex, Rare Diseases International, partnerships between high-income countries and low-income countries, the need for advocacy. Allies, we can't do this alone as the CAH community. We have to work with as many different groups as we can. And finally, Jeff's speech, wow, we had Alyssa, we had Angela, we have Leslie here, we have leaders in the CAH community telling us what we need to do and leading the way. And for all of us working in this space, we just have to keep coming back to that framework, keep coming back to the CAH community. And I can't thank you all enough for everything you do. And those passionate, caring doctors. I'm looking at the team here from Indonesia. Hello, Dr. Agostini. Love you. The caring doctors in the Philippines, in Colombia. The CAH community, we can't do it without allies. Dr. Esty, you're down there. Just thank you all. So with that in mind, I just would like to close today. Thank you to our young people. You've been legends. You've been working like demons for weeks and weeks and weeks and weeks. Thank you for everything you've done. We're just so grateful. So onwards and upwards. Nikki, Katie, do you want to say something about the ECOSOC Youth Forum?
Yes, I just wanted to provide the closing remarks and to mention that as well. So our event has now concluded. Thank you to everyone who has been involved and for your support in the success of our parallel event at CSW69. CLAN is unwaveringly grateful for the support of our community and allowing us to do the work that we do. And we hope that your support will continue us into the future so that we can continue our impactful work. A recording of today's event and report will be made available on CLAN and Mates for Kids websites. To stay up to date with CLAN's work, please connect on the Knowledge Action portal and follow us on social media, where you can find us on most platforms. Our contact information is available on the slides right now. Please don't hesitate to get in touch and learn more about the work that CLAN and Mates for Kids do. And also, please mark your calendar for CLAN and Mates for Kids' first ECOSOC Youth Forum side event on April 16th, where we will be discussing the integral role youth play in advancing NCD efforts, and there should be a link going around in the chat. We look forward to what we can do and achieve when we work together to make newborn screening accessible, as well as access to medicines, and to leave no child behind. Thank you once again.
Bye. Thank you, everyone.